parmi vous. Je vais donner mon présentation en anglais parce que, premièrement, il y a beaucoup de choses techniques que je vais décrire et deuxièmement, et particulièrement parce que mon fils, qui parle très bien français, me dit que mon accent est insupportable. So, I'm going to focus particularly on MRI and drug development for progressive MS because that's the area in which I've received this very generous grant from the International Progressive MS Alliance, which is supported in part by the MS Society of Canada and of Quebec. This is an overview of what I'd like to discuss. I'd like to touch on a number of topics that are related. The first is the difference between relapsing remitting MS and progressive MS, and the differences in the mechanisms of neurodegeneration that underlie a disability progression in the different forms of the disease. I'd like to give you some idea of why there are no treatments approved for progressive MS, what some of the challenges are. And then finally, give you a little bit of insight into treatments that are in fact coming for progressive MS and what it is that we need to do, at least from the point of view of MRI, to facilitate the development of new treatments and better treatments. So MS is an inflammatory and degenerative disease. Many of you probably view MS as purely an inflammatory disease. That's very common. But the degenerative aspect of the disease is very important. In MS, the body's immune system attacks myelin, which is the covering around nerves. And that's what is associated with the inflammation in the brain that causes the relapses and is seen on the MRI. But associated with this, more subtle, is the fact that the nerves degenerate when they are either particularly attacked in one of these inflammatory foci, or just when they exist in the brain of a patient that is who has this immunological activation and an environment that's very inflammatory. This slide shows a nerve. It consists of an axon, which is in orange there. That's the wire, effectively, that comes from the nerve cell body that transmits the electrical signals that make things happen, either make a muscle move or allow you to feel something. The blue cell you see with the red nucleus in the middle is an oligodendroglial cell, a cell that forms myelin. And you can see that this one cell supports many different axons, one of which is shown here in cross-section. And this cell kind of wraps its processes around the axon and accomplishes two important things. One is it changes the way in which the axon or the nerve fiber conducts its electrical signals. It makes that more efficient. Also, it actually has a mutually supportive relationship with the axon. So molecules and signals go back and forth between the myelin and the axon that are in fact important for the survival of the axon in the long term. I have a couple of animations to show you how a nerve cell conducts electricity and how the myelin affects this. In this particular slide, you can see the white bar, which represents the axon, and then these little complexes, which represent channels that let electricity flow between the axon and the outside and allow the signals to be conducted along the axon. In an unmyelinated axon, such as you see here, the signal moves along, like you saw, as a wave of electrical excitation that moves down the nerve. In a myelinated fiber, the myelin covers most of the axon, but every at intervals, there are these same complexes that allow the electricity to flow between the nerve and the outside and for the signals to pass. What this accomplishes is that the signal actually moves much more quickly because it basically jumps from each node, each internode between the myelin instead of having to go slowly down the entire axon. So I'm going to show you this again. This is the unmyelinated speed. Sorry, and somehow we didn't get the myelinated speed, but it's quicker. What happens when you get a lesion in relapsing remitting MS is that there is a vessel, usually, which allows inflammatory cells from the circulation to get into the brain. And that vessel is shown. I don't have a pointer, but it's shown in the middle of this slide as the black hole, essentially, with the white circle around it. The rest of the slide shows nerve fibers in red and myelin surrounding the nerve fibers in green. When an MS attack occurs, there's an infiltration of inflammatory cells from a vessel into the brain. These cells attack the myelin. You can see that the amount of green is less where these inflammatory cells have infiltrated the brain. And at the same time, they actually affect the nerves, and I'll go into this in more detail in a minute. A lesion like this is, in fact, what you see when you do a MRI with gadolinium, because this vessel, because it's inflamed, actually becomes more leaky and allows the gadolinium that's injected into a vein to actually leak into the brain. And this gadolinium can then be seen on the MRI, as you see with those two bright white spots on the image. This is why we do MRIs with gadolinium in patients with MS. In fact, it's not really essential to have an injection of gadolinium. Many of you will probably have MRIs that don't involve an injection. And that's okay too, because when this active inflammation occurs, and in fact even after it has resolved, these areas of focal inflammation that you see shown by gadolinium enhancement leave behind an area of abnormality on the MRI called a T2 lesion. And you can actually see these accumulate as well as evidence that there has been an area of inflammation in the brain that has taken place. Now, when an inflammatory episode occurs, you can see in this panel under A, there's a nerve that's got myelin coating that's normal. Under E, you see a nerve that actually has been attacked by inflammation in the middle. And these inflammatory cells have eaten up the myelin so that it's basically degenerating. But the inflammation has been sufficiently intense, sufficiently severe, that it's also damaged the axon. And if you look carefully, the orange axon in the middle has been interrupted. It's been effectively cut by the local inflammation. When this happens, the portion of the axon that's no longer connected with the cell body, which is at the top of this slide, will actually undergo degeneration. And in the panel B, the third one from the left, you see that there's no longer any axon after the point of inflammation. And what happens in this case, particularly if the inflammation is close to where the nerve cell originates, close to the cell body, then the whole thing will actually degenerate, including the cell body. If it's not close, then the cell body may stay in a kind of handicapped way, with a bit not in its normal form, but it persists. Now, if the inflammation is not sufficiently severe to actually cut the axon, as you can see here in slide B, then what will happen is that the inflammation will eventually resolve, just like when you have a pimple, an area of inflammation on your face. It gets red. There's a lot of kind of angry inflammatory cells in that pimple, but in a couple of days or weeks, the body will kind of control the inflammation, and the inflammation will resolve. And you see that in the third panel here under C. The inflammation is gone. There's a section of the nerve that's been demyelinated, and it's adapted to the demyelination by inserting these channels that let the electricity pass down the nerve, which were previously located just between each myelin node. Now they've inserted all along that axon in order to reestablish conduction in that nerve. With time, a nerve like this can remyelinate. And if you look at the panel on the right-hand side, D, you see that there's a number of nodes. Now, instead of one, there's two, because the remyelinated nodes tend to be a little smaller than the original ones. But the nerve has remyelinated itself and is essentially perfectly happy now. Unfortunately, remyelination doesn't always occur, and the reasons why it sometimes occurs and sometimes does not occur are not clear. There are a lot of researchers and more than a few companies that are trying to understand what prevents the remyelination from happening, so that they can develop new treatments directed towards remyelination. This is a very active area of research at the moment. But if the remyelination fails, what generally happens is that the nerve past that point of demyelination will eventually degenerate. Not acutely, not during the actual inflammatory event, but some time later, and it could be many years later. This axon that has this area of demyelination is vulnerable to premature degeneration. And this is probably an important mechanism that underlies progression in MS, be it secondary progression or primary progression. And if you think about it, the treatments that are directed against the relapsing remitting form of MS, which are directed against suppression of the inflammation that you see in panel B, are probably not going to be the same treatments that you need to prevent the chronic degeneration of the nerve that you see on the right-hand side of this slide. Okay, one is an anti-inflammatory treatment, like steroids or any of the disease-modifying drugs that are currently available for relapsing remitting MS. These are not going to support the vulnerability of the part of the chronically demyelinated axon that you see in the third panel from the left in order to prevent the degeneration. We need a different kind of treatment, either a treatment that facilitates remyelination or a treatment that enables this chronically demyelinated nerve to survive longer in order to prevent the phenomenon of degeneration and the neurological impairment and disability that is associated with the chronic degeneration of the nerve. Now, one of the things about relapsing remitting MS is that it actually declares itself very early in the course of the disease. This is what allows us to treat it at a point where there has been very little or relatively little injury to the nervous system. And the reason it declares itself is that these focal areas of inflammation produce focal neurological symptoms. It could be weakness of an arm or a leg, or numbness of an arm or a leg. And these things bring the patient to the doctor, who might suspect that this could be a symptom of MS, does an MRI and sees that there are lesions consistent with MS, does other appropriate tests, and can make a diagnosis fairly early in the disease before there's been much brain damage. In fact, what the MRI has taught us is that the areas of focal inflammation in the brain are actually much more frequent than are the clinical relapses. So this is a video of MRIs, monthly MRIs of a patient that have been kind of all aligned together and made into a video. Whoops, that's unfortunately not working. Can the person who's maybe controlling this just hit the down button maybe, and I think this, or maybe the video won't work. Oh well, that's too bad. It's probably my fault. I think I probably didn't include the video file when I sent the talk. So you'll have to take my word for it that for every clinical attack in MS, there's maybe 5 new brain lesions that have appeared that have not had any symptoms associated with them. This slide shows the natural history of MS and kind of recapitulates what I've told you. On the left-hand side of the slide, you see in orange the evidence of a first clinical attack. This has in the past been called a clinically isolated syndrome. And there's a white line across the slide that says clinical threshold. This is the level or the severity of lesion in the nervous system that is necessary in order to produce a symptom. It might have to do with how much the inflammation injures the nervous system. It might have to do with where the inflammation occurs. As many of you know, much of the brain is not really clinically eloquent. You can have a lesion, for example, in your frontal lobe, which makes up half your brain, and you won't feel anything. It doesn't affect the way your muscles work. It doesn't affect the way you feel, a pin or touch. It affects, the way you can analyze a situation and the way you can make more high-level decisions. And this is not something that is something that you are aware of if you have a small problem with. So there may be many lesions that come and go that are not associated with any symptom that's identifiable by the patient, but eventually one does occur in an area of the brain that does produce a symptom, and the patient develops the symptoms that you see at the left on the slide under the CIS, clinically isolated syndrome. At some point after that, there will be more lesions that form, and then a second attack will occur. And this is what used to be called clinically definite MS. Now we can we have different diagnostic criteria, which are based more on the MRI, because, as I've said, the MRI shows more evidence of activity than the clinical relapses do. But the principle is still the same. Initially, the relapses, recover well, and one is not aware of any residual nervous system injury. But if you look at the orange, you'll see that the recovery is not 100%. There is some residual injury to the nervous system, but it's too small to be noticeable by either the patient or the doctor. As relapses go on, this kind of subclinical injury can accumulate, and eventually, as you see in the middle of the slide, you can have a relapse which is not associated with full recovery as far as the person is concerned. There's some accumulated disability that persists even between relapses. And then as time goes on, after 15 or 20 years, in maybe half the patients with MS, progression starts to occur even between the relapses, and that's shown by the orange slope that's getting progressively higher, even between the orange peaks that represent the relapses. And this progression in the absence of relapses is what is clinically defined as progressive MS. Okay, there is a period of time, which can be quite long, where the relapsing remitting features of the disease, i.e. the relapses and the focal activity on the MRI, overlap with secondary progression. And for that reason, people who are on disease-modifying therapies that suppress these areas of focal inflammation will often continue to take these drugs even after they start to show some evidence of secondary progression. But eventually it becomes, the returns of taking this medicine become progressively smaller. And how long that period takes, how many years one continues to have features of both focal inflammation and relapsing disease as well as secondary progression is very individual. Analogous to the focal inflammation, the white spots on the MRI in relapsing remitting MS, we have an MRI marker of neurodegeneration, and it's called atrophy or loss of brain volume. And here on the left you see the brain of a normal control subject. In the middle you see a patient with relapsing remitting MS, and the dark spots in the middle are the ventricles. They have expanded to replace brain that has shrunken, associated with the loss of nerve fibers and myelin by the process that I described to you. And with secondary progressive MS, the brain shrinks even more because of a loss of nerve tissue. So this is a good marker of degenerative disease that's associated with progression. But it actually occurs very slowly. These slides, show only one point in time in a patient with relapsing remitting disease and secondary progressive disease. There may be many, maybe 10 or 15 or 20 years of accumulated problem that resulted in this level of atrophy. In the average MS patient, the loss of brain volume is on the order of 0.5% per year. And this is compared to a normal person who's aging, as I am, where it's about 0.25% per year, maybe even 0.33% per year. So the rate of atrophy is accelerated, but it's still very small, and it's hard to measure in the course of a year or even 2 years. So you can't just do an MRI after a year or two and look at it and decide that there's been significant brain volume loss. You have to use kind of sophisticated image processing techniques in the laboratory to measure changes that are that small, and you have to acquire the scans in a consistent way. So this is information that's not generally available in the clinic and really cannot be assessed except after several years when the changes become big enough that you can clearly see them. So at the end of the day, I think the concept of MS that's emerging is that all patients have both the focal white matter inflammation that I described and also diffuse degeneration. But they are, in fact, different biologies. On the left here in green, you see the focal, you see a graph of the contribution of focal white matter inflammation, which is driven, it says here peripherally driven, which is driven by white blood cells coming into the brain from the peripheral circulation. And its contribution is greatest at the beginning of the disease, and it tends to decrease over the lifespan of the patient. In red, you see the degenerative aspect of the disease, which predominates late in the course of MS, okay, and is not associated with this attack, infiltration of blood cells into the brain, but rather with degenerative processes related to the vulnerability of bare axons that are no longer protected by the myelin covering. And this phenomenon it dominates late in the disease. It's probably present from very early, overlapping the focal inflammatory phase. Whether it starts right at the beginning or whether you have to have MS for some years before this process establishes itself in the brain is still an open question. But it's still a good idea to treat very early in case the factors that are responsible for the degeneration can be prevented by suppressing the inflammation in the brain very early in the course of the disease. In patients with primary progressive MS, the situation is not totally different. It's more a question of quantity rather than quality. These patients have a course that's dominated by degeneration, but the focal inflammation is still present early in the disease. It just tends to be largely below that white line that says clinical threshold. The lesions are coming and going. They tend not to produce symptoms of a relapse. And so the patients present not at the time when the disease is very early on the left of the slide, but only when that red slope crosses the clinical threshold, which is, in this case, let's say 15 years from the onset of the disease, and usually 10 or more years later, in terms of age, than the patient would have presented had the early focal inflammation been associated with relapses that would have been evident sooner. So how has MRI contributed to the development of drugs for MS? The entire story is summarized on this slide. So along the horizontal axis, we see the suppression of focal inflammation on MRI, the suppression of gadolinium enhancement or new T2 lesion formation. The numbers, of course, are negative. On the vertical axis, we see the suppression of relapses, and this is not in the same trial. This is in different trials. So the way that MRI has been critical for the development of drugs for relapsing MS is because one can do a trial, an MRI trial, to look for suppression of the focal white matter inflammation in, let's say, 100 or 200 patients followed for 6 months. That's a relatively small trial. You can have more than one dose arm in this trial, and you can figure out relatively inexpensively how effective your drug is at suppressing this inflammation. And you can be confident that whatever you see on the MRI in this early phase 2 trial will in fact predict the suppression of relapses in a larger phase 3 clinical trial, which is the kind of trial that's required to actually get a drug approved for use in Canada or any other country. And so these phase 3 trials are very expensive. So the trick in relapsing remitting MS has been to do these phase 2 trials with an MRI readout, figure out if the drug's effective, what your best dose is, and then embark on your large, expensive phase 3 trials that might involve 1,000 patients or sometimes almost 2,000 patients. Unfortunately, and one of the challenges of developing treatments for progressive disease is that we don't have an MRI marker which will tell us if a drug is likely to prevent progression, the same way that we have an MRI marker that tells us if a drug is likely to prevent relapses. And there have been many examples of this. The best one is the most recent one, which is the INFORMS trial of fingolimod or Gilenya in primary progressive multiple sclerosis. This slide shows the suppression of the MRI lesions by Gilenya, which we know is quite effective. And here you see at every point, 12 months, 24 months, and 36 months, there has been, 70 to 80% plus suppression of the new lesion formation in the brain. So if we're treating relapsing disease, this would be associated with a very effective suppression of relapses and progression associated with relapses. Unfortunately, in patients with primary progressive MS, this suppression of the focal white matter lesions on the MRI was not associated with any suppression of disability progression. So here you see in gray and orange the rate of progression in this trial of patients on placebo and on fingolimod, and the curves are essentially overlapping. And so here we have a dissociation of the MRI markers that are so useful in relapsing remitting disease from the clinical outcome that we're trying to achieve. Here we see the brain atrophy in patients in the same trial. And what you see is that, in fact, the drug has failed to suppress brain atrophy, just like it has failed to suppress clinical evidence of progression. So the brain atrophy is still following the clinical progression, but it's not. It doesn't have the same power to actually have a readout early on that will identify whether the drug is effective on suppressing progression or not. So the INFORMS trial, I'm just guessing here, but probably cost about $100 million, and after this was completely, totally negative. There have been many other trials in progressive MS that have also been negative, and I've listed a few here. There was the North American trial in secondary progressive MS of beta interferon, PROMISE trial of glucocerebromotor acetate, the Maestro trial of myelin basic protein, the Olympus trial of rituximab, most recently the ASCEND trial of natalizumab or Tysabri. Each of these trials is, cost on the order of $100 million, if not more. And this doesn't include the cost of getting the drug to the point where you're ready to do a phase 3 trial, which is, more like $1 billion. And so you can see when most of the trials are negative, you have no way of screening the drug early on to decide if it's going to work or not. There is a reluctance on the part of drug companies to embark on the development of drugs for progressive MS. It's very expensive, and it usually doesn't work. What we need, at least from the MRI point of view, aside from drugs that work, is the equivalent of lesion suppression on the MRI, which is a useful marker in relapsing remitting disease, so that we can do phase 2 trials in progressive disease and decide before we spend hundreds of millions of dollars on the phase 3 trial whether the drug is likely to work and what's the best dose. And that brings me to the description of the recent grant that I've been fortunate to receive on behalf of researchers around the world to try and develop MRI markers that will actually be useful for early clinical development of new drugs that will treat progressive MS. The idea behind this proposal, if I can kind of summarize it, is that instead of trying to use things that we measure already and see if and use them to predict whether a drug will work or not, or is working or not, we in this proposal will actually try and find new markers that we've not measured before, that we don't even necessarily know how to identify, but that we will learn we will learn to identify using advanced computer image processing techniques, particularly artificial intelligence or machine learning, or what's usually called deep learning. Okay, so we're not measuring brain atrophy. We've been measuring brain atrophy for a long time. It's not bad, but it's not good enough. We need something better that will perform as well as gadolinium has performed. And the idea of using deep learning is not that uncommon these days. Many of you have probably heard about this in many other fields. What has inhibited this area of research up until now is the computing resources that are required. It's to develop these deep learning machines or deep learning algorithms. You need very, very powerful computer processing, which has only become available in recent years. And once it has become available, it's being used in more and more areas. An example here is taken from Facebook, which uses deep learning for facial recognition. You see here a picture of an actress, and then the different levels of a deep learning algorithm that are identifying features of her face which will allow the algorithm to recognize her. And the first level is not that different from her, right? You might recognize her as well. But when you start to get to the second, third, fourth panel, it's looking less and less like her. And then as you get to the right half, it's identifying characteristics of her face that don't mean anything to us, right? It doesn't even, at the end there, it doesn't even look like a face. But those are features of the image that the algorithm has decided are the most discriminatory and will allow it to identify this person. And this kind of technology, I think I put it there, it's 97% accurate in facial recognition, so it's extremely good. Okay, the idea in our research plan is to use this kind of approach to identify characteristics of the MRI of patients with progressive disease that are associated with progression, so that at the end we'll have a deep learning network that can be applied to images that will predict if a patient is going to get progression, and also it can be used in the trials, the early trials, as an outcome measure of progression that's more sensitive than simply using the old clinical disability scales. These disability scales have been useful, but they're very noisy and they're very insensitive, and they require trials that have 1,000 to 2,000 patients that cost hundreds of millions of dollars. That even drug companies with their deep pockets think long and hard before they embark on clinical trials like that. If we had MRI markers that would let them decide in a trial that's only a few months long with, only 10% that number of patients, they would be much more inclined to try new drugs. And this is the idea that we will be investigating over the next couple of years. Having been rather negative about the field of of treatment for progressive MS, I'd like to finish by talking about recent successes, because in fact there has been a recent success in the treatment of progressive MS. Many of you may have heard of this drug called ocrelizumab, which has recently had a successful trial in primary progressive MS. This drug is not available actually anywhere in the world yet, but it was approved a couple of weeks ago, maybe 1 to 2 weeks ago, by the FDA in the United States for treatment of primary progressive MS. It's been submitted to Health Canada, who will make their own decision, but will most likely also approve this drug. Which will then have to get accepted by every province on its formulary, but which, should be available in Canada for primary progressive MS, in something on the order of a year. Don't hold me to that. I don't even know for sure if Health Canada will approve it, but if things go well, it's usually about a year after between this stage and the final availability of a drug like this on provincial healthcare plans. This shows the level of efficacy of ocrelizumab in primary progressive MS. There was a 24% reduction in the risk of confirmed disease progression. The distance between these curves, and it's not penicillin, it's not a miracle, but it is a significant, a clinically significant slowing in the rate of progression. There's been another trial recently in patients with secondary progressive MS as opposed to primary progressive MS. This drug was siponimod. It's closely related to fingolimod. And it reduced progression by 21% compared to placebo in a single trial. So here you see the effects of the cost of doing these trials in the absence of a good MRI marker. So, for secondary progressive MS, to get a drug approved, you usually have to do 2 trials. The company decided to take a chance on only 1 trial. They will, I don't know if they will get approval based on a single trial. I'm sure they're in discussion with regulators about this. If the regulators decide they need 2 trials, then it'll take another 5 years to do another trial before a drug like this is available on the market. So this situation is more fluid than the one with ocrelizumab, but it's still promising. So to conclude, there is hope for the treatment of progressive MS. There have been some successes recently, and we hope that by developing better MRI markers that can identify drugs that work earlier and cheaper than is possible at the moment, that there may be more treatments coming and better treatments. Thanks very much.